I will be continuing from where Dr. Rashmi has left this academic deliberation, which means we are going to now talk about the ventilation in patients with severe COVID. And of course, the focus is on oxygen therapy. Let's look at a patient who is 40 years old. He is a diagnosed case with COVID. His respiratory rate is 32 per minute and saturation on room air is 75%. With a correctly fitted, nicely functioning, non-repeating face mask at a flow of 15 liter per minute, let's say, which means FiO 2.9, the saturation is now 87%. Two questions. First, is this severe or is this a moderate disease? Now, it's obvious that since the respiratory rate is more than 30 and the saturation is less than 90% of room air, yes, this is severe disease. Second question, can you do anything? No drug, no device, but can you do some maneuver or change something about the patient which might help him? Yes, in COVID, there is one highly beneficial maneuver which has been practiced right from the first wave onwards, awake self-proning. The word describes what it is. Patients with moderate disease, patients with severe disease, even with mild disease at home, we encourage them to lie prone. That means to lie on your stomach, maybe put a pillow under the chest. And in this particular patient, you can see that the saturation picked up from 75% straight away to 94% after 15 minutes of proning. 4 to 16 hours per day of proning is supposed to be the target. A good way of doing it is 30 to 120 minutes in the prone position, 30 to 120 minutes in right lateral, then the left lateral, and then supine, and so on for the entire day. If we look at the management guidelines from Ministry of Health and Family Welfare for severe cases, respiratory support, you'll see that it starts by saying to initiate oxygen therapy at 5 liter per minute. That means that we first need to use standard oxygen therapy, not at low flow rates, but a minimum of 5. If you reach a target saturation of 90% or above in non-pregnant and 92 to 96% pregnant patients, then this is fine. In case it fails, then we consider the use of non-invasive ventilation or a high flow nasal cannula. If that also fails, we need to go on to intubation and traditional mechanical ventilation. Now, supposing we had the same patient and he had not responded to the standard oxygen therapy, he had not responded to awake proning, what other oxygen therapy modalities did we need to go on to? I just showed you the guidelines. So the next step would be to use either a high flow nasal cannula or a non-invasive ventilation. So let's take up high flow nasal cannula first. This is what it looks like on the patient's face. The principle behind high flow nasal cannula is that it uses the 3 H's. That means it has a high flow. First H is for high. Standard oxygen therapy, if you recall, the face masks were using up to 15 liter per minute of oxygen. Now in this, you can deliver up to 60 liters per minute. So that's almost 4 to 5 times. So it's a large jump in the flow of oxygen. Second H, it is humidified. There is a humidifier attached. And third, it is heated to body temperature. This is what the apparatus looks like. Now, once you have this heated, humidified, high flow of oxygen, you need to conduct it or deliver it to the patient. This blue colored tubing is the delivery tubing. It's made of, it is lightweight, it is flexible, and this finally connects to a nasal prong, which you fit into the patient. How do all these connections come in together? I'll show you a video just after this slide. We usually start a flow of 20 to 30 liter per minute, not 60 straight away, but it has to be more than 15 because obviously the patient had failed standard oxygen therapy with 15 liters. So 20 to 30 is a reasonable flow that we start with using an FiO2 of 0.4. If it doesn't suffice, we first increase the flow by 5 to 10 liters every time. You can go up to 60 till saturation is maintained. If it is not maintained more than 90%, remember, we are not aiming for 100%. As long as it is more than 90%, we are happy. The respiratory rate should start coming down. The patient should look more comfortable. The distress should settle down. If it doesn't, then we also can increase the FiO2, the oxygen percentage. And this we increase in amounts of small little, 0.5 or 1. That means 5 to 10% only, not more than that. This video will now show you how the HFNC apparatus is actually set up. This is what it looks like. You can see the blue delivery tubing, you can see the machine, you can see this dark gray part. This is the control panel on which you will be setting up the flows and FiO2, okay? The first thing to be done, which we do for any machine, is this is just showing you the distilled water which is going to be fed into the humidifier. Going back to the first step, what do? An electrical input. Whether it's a ventilator, whether it's a BiPAP machine, whether it's an HFNC machine, they have to be plugged on. Now the machine has to be, or the control panel has to be put on. There. So the machine has come alive. You can see the display with the electrical input. You can see it displays a lot of things. And there's a small lock here you can see, right? We are trying to change everything, nothing changed. It kept being locked because it did not have the pressurized oxygen source into it. So there we plug it in. Does that change anything? Yes. Now the lock, when you press, it has become unlocked. Now you'll be able to change the FiO2 as well as flow. Now this flow currently is 11 liters per minute. We are increasing it, and let's say we go up to 60 liters. That's the maximum. The choice is between an adult or a pediatric patient. So I'm choosing an adult. Below that, you can see it's 37 degrees Celsius. That is for the heating temperature. Now it's 32. When I chose a pediatric patient, I've increased it to 34. This white is the nasal prong, which is going to go inside the patient's nostrils after connecting it to the delivery tube. For every patient, we have to use a new nasal prong. Let's see how they're going to connect this to the delivery tube and the other end to the patient, and then adjust it on the patient with a flexible elastic strap and make the patient comfortable. This is the flow meter. Unlike the flow meters we had shown you, which are connected to cylinders and wall outlets, this flow meter is capable of delivering a much higher flow. You just see the markings, they're almost up to 50 liters per minute for this one. There it goes into the patient. Two prongs, one in each nostril. No, not correct. There, it's been corrected. Despite being lightweight, the prongs can slip out of the nostril because of the weight. So there is an additional strap here to make sure that that doesn't happen. And the HFNC is ready to be used. It can be considered that why should all of us know about HFNC? You're not going, maybe a lot of us are not going to actually end up initiating it. But see, COVID is a disease in which all specializations, all barriers which we knew have been broken. All patients are suffering from one disease. We are all treating one disease. So any and every help is welcome. Given the kind of work pressures we've had, if all our healthcare workers are aware what an HFNC looks like when it is in use, you will definitely be able to help by maybe detecting a disconnection, seeing that the control panel is not on, maybe the oxygen flow meter is not on, or maybe that the wire got disconnected. So yes, knowledge is eventually going to help our patients. The second modality, we said non-invasive ventilation. Maybe a few of you have not heard the word non-invasive ventilation, but everybody by now is familiar about BiPAP in COVID patients. So are they the same thing? Not really. How they are different, I'll come to it. When I say non-invasive ventilation or NIV, we mean that we are providing ventilation, but by non-invasive method, which means we are not putting an endotracheal tube. Then how are we connecting the ventilator to the patient? Through some kind of a mask. Now in the first picture, what you see is an oronasal mask, which means it covers the nose and the mouth. This is what we use mostly. There can be a full face mask as seen in the next picture. We don't use these in our institution, nor are they available. Third could be we could have just a nasal mask. Again, we are not using very commonly. Fourth is a helmet in which the entire head is present inside this transparent helmet. It sits snugly and comfortably around the neck and the upper part of the chest. BiPAP, on the other hand, is a mode by which I ventilate when I am using non-invasive ventilation. That means I'm using the ventilator through that mask connected to the patient, and the settings I make on this ventilator or the machine is a combination of two pressures. So bi to PAP pressures. So it is a bi-level airway pressure that is used in this mode. Is it a new thing? No, non-invasive ventilation is not a new thing. Okay, it was being used prior to COVID also for both patients who had gone into respiratory failure because of rise in CO2 or a fall in oxygen. But what has happened is that with COVID now, it has become a way more standard therapy. There are certain, however, presence of certain factors which absolutely contraindicates non-invasive ventilation, however much you may want to use it rather than intubate your patient. An unconscious patient, a patient with apnea, a patient with so much of respiratory secretions that he's unable to clear his passages, or he needs to keep coughing all the time and spitting it out, you cannot have a non-invasive ventilation in place. How do we set up a machine to deliver non-invasive ventilation? Now, as I said, NIV can be delivered. The machine can either be a ventilator on which we are going to set BiPAP, or it can be a BiPAP machine itself. Either way, setting them up needs certain common prerequisites or certain common things, which we'll just see in this video what they are. First thing, again, electrical inlet. Putting on the machine, you'll see the machine come alive. The control panel will start displaying after electrical input. The pressurized oxygen source has to go in. And you see that the control panel is now functional. You also see that the delivery system or the breathing circuit is in place. Two tubes, one for inspiration, one for expiration, connected to humidifier. Humidifier should have water till the minimum marked level. And the circuit ultimately is connected to the mask. So this is an oronasal face mask for NIV, which will be connected onto the patient. Now, once you set BiPAP for NIV, this is what a pressure waveform will look like. Can you see? It's a higher pressure. This figure shows you a high pressure and a low pressure being repeated for every respiration. Let's say the high pressure is IPAP because it's given during inspiration, and the lower pressure is EPAP because it's during expiration. Of course, you have to set the time duration for both pressures. So there are 4 things that you are setting: 2 pressures, 2 times. Let's see, when using a ventilator, how are these settings being made? First, BiPAP mode is selected there. Now, if you see this upper section, it's a flat line, no waveform. The moment this pressure is set, this yellow extreme left down, you start getting these humps, pressure humps on the tracing. Now, both the pressures are being set for 2 different times, and you can see that the waveform now looks like the typical BiPAP waveform that I had just shown you in the previous slide. This yellow tracing, you can see a high pressure and a low pressure. Of course, the FiO2 also has to be set. Now, supposing you were to choose between setting both the pressures, to really simplify, just remember that the higher inspiratory pressure has to be raised so as to get a tidal volume. The higher you go, more tidal volume you will generate. Once you achieve anywhere between 6 to 8 ml per kg, that IPAP is adequate. EPAP you can increase to increase the oxygenation. Having said that increase in both pressures is required, we need to remember that the increases have to be very gradual, not more than 1 to 2 centimeter water at a time. Difference between both pressures should always be maintained somewhere between 4 to 10 centimeter of water, and never make the pressure so high that the patient is getting uncomfortable and cannot breathe, because that high pressure is going to throw the oxygen onto his face, the oxygen air mixture. It should be aimed for his comfort also. Rather than a ventilator, during COVID, you must have seen a lot of patients on NIV with these small machines called the BiPAP machines. Now, BiPAP machines are an old concept, and these machines were being used for certain specific diseases like obstructive sleep apnea and COPD, but mostly for treatment at home. With COVID and the large number of patients who required NIV, the shortage of ventilators, using BiPAP as a mode, BiPAP machines were also used, provided we could supplement oxygen into them, provided the pressures which were allowed in them were not too little, not small enough just for a COPD patient at home. And if they had humidifiers, then nothing like it. So BiPAP machines have also been used. Now, instead of BiPAP, another mode which is used during non-invasive ventilation has been pressure support ventilation. I'm not going into the details. For any of you who is interested in knowing about this, I'm willing to take the questions later. Is it that non-invasive ventilation is all safe and very nice, and that's why we are trying to use it and not intubate? That is not true. Firstly, mechanical pressures and sores on the face are a major problem. The mask has to be tight-fitting to deliver this non-invasive ventilation. So obviously ulcers, necrosis on the nasal bridge, we've been seeing a lot of them. What you have to prevent is and make sure that there are no ocular abrasions. So even if you're walking past a patient on NIV and you see that the mask is impinging onto the eyes, it needs to be readjusted. You might find quite a few patients who do not accept NIV very well because it causes a lot of anxiety with that mask sealing their mouth. They're not able to talk, they're not able to take in food freely or drink water, and claustrophobic patients find it even harder to accept this. Of course, there's a lot of oronasal mucosal dryness with such high flows coming straight into the mouth and the nose, especially if there's no humidifier on it. So we have to remember to be empathetic to these patients, to counsel them, to encourage them, to be with them, for them to be able to tolerate NIVs. 2 physiological complications. The higher the pressures you use, normally we do not like using higher than 20-25 centimeter of IPAP traditionally for BiPAP modes. Now, higher pressures means more chances of barotrauma, that means pneumothorax, pneumomediastinum, and more of hypotension also. Finally, in severe COVID, if your patient has failed standard oxygen therapy, has failed NIV, has failed HFNC, we will have to resort to intubation and mechanical ventilation. We are not dealing with it here specifically because that is a highly specialized area meant only for a certain few trained hands. But what you could know is that if you were to encounter patients who are unconscious, who have multiple organs which have become dysfunctional or have failed, or patient is in shock, then that patient needs an alert for immediate intubation. At the end of this talk, my take-home message when dealing with the ventilatory strategy for severe COVID patients will be that first, the ventilatory therapy or respiratory therapy in these patients has to go stepwise. It has to progress from standard oxygen therapy to NIV or HFNC, and intubation can only be a last resort. And in case you are trying to help or individually initiate any kind of machine for oxygen therapy, whether it is a specialized ventilator, or it is a BiPAP machine, or it was a high flow nasal cannula machine, please remember, they will all be needing an electrical input. They will all be needing a pressurized air source, whether that is coming by putting in a compressed air to the central wall inlet, or an oxygen inlet, or it's a turbine base, but that air has to be flowing out of your machine. Thirdly, they will all need a source of oxygen supplementation. They will need some kind of a delivery tube from the machine to the patient. That's what we call breathing circuits, which have to be connected to the patient by mask or maybe an endotracheal tube. And finally, it is a must to use humidified gases in all patients, because not only does that make breathing easier for patients, it also decreases the chance of secretions sitting into the lungs of patients and increasing infections. And with this message, I would like to say a thank you for your patient hearing. I hope the session proves useful in certain ways to everybody. Thank you.